Did you know that Black patients are 40% least likely to receive pain medications in comparison to their white counterparts? Or are you surprised that even in the year 2025, we still have medical and clinical protocols that put race as a factor into deciding whether someone gets a certain type of care? And unfortunately, right, well, whether it was well intended to begin with, it has continued to hurt Black patients over and over and over again, especially in a system that already didn't start off on the right foot with them in the first place. And as a physician with over a decade experience, I've seen time and time again where unfortunately just being Black, when you just knock off all of the other issues, just being Black in this medical field, in this medical system, puts you at a detriment. So today we're going to be talking about how kind of medical racism still plays a part to this day. And more importantly, what can we do about it when we recognize that, hey, a problem may be afoot? All right, so I want to talk about today that even with all of the medical advances, let's talk about the problem that really medical racism is, right? Even with all the medical advances, like to this day, right? You know, I love my numbers. Black women, right? And we actually had an amazing conversation. Please check that episode out. Black women are 3 to 4 times more likely to die from pregnancy-related illnesses than white women, right? Just being Black. Black patients are 30% less likely to be referred for advanced treatments like kidney transplant, transfusions, dialysis, like just being Black, right? So there are factors that are hitting us day after day after day where we see that just being Black puts you at a hindrance. And I remember especially when I was medical student, medical resident, and I would start reading a lot of the studies, especially I was really enamored with like blood pressure, just cardiac. Cause I thought I was going to be a cardiologist at one point, right? Cause I really set my heart, I was like, I could do cardiology because I really like cardiology in the field of it. But when I started to read how many studies were out there that had a low participation rate of Black patients, but was able to make this generalized inference on which medications did better, perform better. If you had a Black patient, you should give this patient this medication versus that one. Like it was almost astounding. And we talked about this when we had our conversation with Adam Walker, definitely an episode you check out when we talked about AI and like how can AI play a factor in our research. This is what happens, right? When you have a system that's already faulty, when you have a foundation that's already kind of shaky, and now you're forced to make an inference on an entire population because the numbers coming in isn't a lot. So you just have to kind of make really, I don't want to say a guess, right? But it is an educated hypothesis to say, hey, you know what? Based on who we did have in our study, we think this medication may be, beneficial. We can't then turn around and blame the patients when that medication doesn't seem to work, right? And that happens a lot where when you look at the studies didn't have that many Black patients in there, but the study said you should give this to Black patients. And then when we have our patients who don't do well with that medication, we say, oh, it must be something wrong with the patient. Like, no, it was from the beginning, from the start. And again, we can talk ad nauseum about like how we got here, but I've got plenty of episodes on that. But I think today is just a matter of kind of saying the quiet stuff out loud, because I think that's important. If you follow this channel, you understand that like in this channel, we try to say the quiet things out loud when it's good or not. Like when something is good, I'm a screaming from the rooftop. But when something is not good, I'm going to let my Lunch and Learn audience know like, hey, we have to watch out for this, right? So I think that's important, right? And then this is another one. Studies have shown that when patients are treated with race-specific assumptions, they are more likely to receive suboptimal outcomes, whether it's pain management, cancer screening, cardiovascular treatment, right? So again, just to kind of sum up why this is such a problem, that we're now doing studies based off our suboptimal studies, and we're confirming that like, yeah, like that's probably not the best route. So I think it's one of those things where as a physician, as a healthcare provider, because again, I always say now that I'm on the other side, I'm still a patient at times. But when I'm on the other side as a healthcare provider, I have to be educated enough to understand that when I'm prescribing my patients certain medications or certain treatment regimens, what is that foundation coming from? Is it something I just read in the book? And if it is, like, did I do a deep dive and say, all right, where did they get their numbers from? This is what we tell people all the time. Empower yourself for better health, right? Like if as a physician, I'm going to empower my patients and they're going to entrust in me that what I'm doing is the best for them, I have to make sure I do my homework. So this is, I think, conversations like this is where it starts, because this is when you start asking yourself, like, all right, did I prescribe that medication because I really thought it was the best medication? Or did I prescribe that medication because the study said that this medication would do better for this specific race? And if it's the latter, we got some work to do, y'all. All right, I want to talk a little bit about, obviously, my journey of how I even got to this point where I felt this was a conversation that needed to be had. I remember as a medical student kind of reading up on some of these journals and some of these studies, stuff that I had to memorize. And I started really noticing this pattern that the studies that I was, forced to memorize or was told was the gold standard. When you go to look, and I've said this a lot on this channel, one of the reasons why I love having a public health degree is that it really showed me how to really read and dissect a lot of these journal articles. Because I remember when I used to read journal articles, I would read it, I would, get the numbers, the P values and all that, but I didn't read to understand. It wasn't until I had the help with my public health degree where I started almost reading to say, like, is this article trash or not? Like, I got to the point where when I'm reading an article, I'm reading it to see, like, all right, is this a bad study? Is this something that I can throw away complete? Like, I'm not assuming that it's a good study because it happened to be published on, the New England Journal of Medicine or JAMA or one of those things, like, or Annals. I'm not reading it in that sense. I'm reading it saying, hey, I don't care where it got published. I'm going to confirm to myself, is this actual good study? And I started noticing that a lot of the protocols were really based on this subjective racial assumption, right? And the biggest one, and this is one where me and a good colleague of mine, because I'm a part of the American College of Internists, and when we started looking and saying, like, hey, like, look at these protocols that are out here, the biggest one was GFR, right? The estimated kidney function. And for years, Black patients were given a higher estimated GFR, specifically because of their race. And you may be saying, Dr. Pierre, like, all right, what does that mean? What does it mean in layman's terms, right? Because at the end of the day, if I can explain it to a 3-year-old, a 10-year-old, a 40-year-old, a 60-year-old, that's how you know that the teaching's right. So you have Black patients, because they were Black, they were giving a score that was a little bit higher than what if the person happened to be white. And you may be saying, why is that a problem? Typically, when we start thinking about treatment options, when we start thinking about treatment endeavors, especially when it comes to the kidney, like, hey, when do I refer to a kidney specialist? When do I start talking about kidney transplant? When do I start talking about dialysis? When I start thinking about those things, I'm doing it based off these numbers. And if I am being told that because this person is Black, that their number isn't as low as I expect, like, because they're giving it a fictitiously higher number, I'm going to delay when I make those moves. Let's say the cutoff number is 5. And I have to wait till you get to level 5 before I can even do anything. But for years, you remain on level 6 because you're a Black patient, and the calculation says give them a bump. That's cool, right? It may sound good until you realize that this person who is rated as a 6 should have been rated as a 5, which means they should have been referred to the kidney specialist earlier, which means they should have been referred to the kidney specialist about a transplant earlier, which means they should have been warned that, hey, you may be going on dialysis earlier, but they didn't. So all of a sudden, that 6 just kind of tracks along, and then boom, they drop to a 4. And all of a sudden, like, oh, I'm behind the 8 ball, versus if it was a white patient, more importantly, non-Black patient who was correctly rated as a 5 a year ago, they were given that referral to the specialist. A year ago, they were given that conversation about kidney transplant. A year ago, they had conversations on what they need to do to avoid, going on dialysis, right? So you can understand how timing is everything. We talk about this all the time. Timing in medicine is a matter of life or death for a lot of people. So you had a person, patient A, who, because they were Black, for a whole year, they were on the, oh, you're okay track, versus patient B, because they were non-Black, like, they were like, no, you need to see the kidney specialist. You need to go see this person and this person. You need to have interventions done earlier. You can understand how that's a problem for us, right? So when me and my friend, we had our conversations with the organization, we were like, hey, we need to do something. We need to say something, because we can, my friends, Dr. Watson Duke could tell, we actually had him on an episode a long time ago. We'll see if we can get it back back on the episode. He's not very social on the podcast front, but we talked about like, hey, we need to like have a conversation and more importantly, put some type of statement out that says like, hey, this is a no-go. And it was through a lot of hard work, and it was actually through several organizations where like, you know what, they got to the point where they said, yeah, get that out of here. And that was one of the first times I realized that, okay, like, yeah, I need to actually pay attention to this. I need to pay attention when I say things like, oh, this medication works better in Black patients. This medication works better in Asian patients. This medication works better in Hispanic. I need to be careful and really verify, where am I getting that information from? And what is it based on? Is it based on facts or is it based on assumption? Because we see in this field of medicine, a lot of things preemptively were based on assumption that we just kind of ran with it. And we can't run with it no more. Not in the year 2025, where there's so much information, so much data, so much ways to get the appropriate answer that we need to get. We can't rely on an assumption that may be faulty. So you say, all right, Dr. Pierre, so what do we need to do here, right? What do we need to do? I'm a healthcare provider. Let's say I'm a healthcare provider, or I'm a patient. Like, what do we need to do here? We need to, especially for my Black patients, we need to be very, very informed on the reasons that we're given medications, the reason why we're given our directions that we're given, and have a good foundational basis to understand like, okay, I'm given this not because it's the best medication for a Black patient. I'm given this not because it's the best treatment option for a Black patient. No, I'm given this because it is the best treatment option, period. Like, we have to be that defined in saying, hey, is this the best option for me? And when I say for me, I mean a person who has blank disease, not a person who happens to be Black with blank disease. Is this the best treatment regimen for me? And then when I flip the camera and I say, hey, healthcare providers, doctors, nurses, nurse practitioners, PAs, whoever's taking care of these patients out here, ask yourself, like, am I doing what I need to do for the patient in front of me, not relying on the fact that, oh, because they happen to be of a certain race, this is the best medication for them. And I'm not sitting here and telling you that there may not be studies. I'm not sitting here and telling you that, oh, if it's a race-based study, like, get away from. No. I'm just saying, make sure you trust and verify that the study that was provided, the information that you got, was sufficient for you to be like, you know what? I trust this information. I'm smart enough to relay this information for my patient. Hey, I'm giving you this medication here because study after study after study have shown that for Black patients, it does better. That is how we need to do these things. Not, I'm giving this medication here. The study said it was cool, but I didn't really read it. Like that, we don't have that excuse no more, especially now. I was talking to a colleague of mine in the hospital where, when I was a resident, and because I'm a former program director, right? So when I was a resident, we used to have our pockets full. Our white coats used to be full with these like pocket medicine and Stanford Guide, and like we used to have just pockets full of information, right? Because a lot of stuff wasn't available in the palm of our hands. Now, like when I look at some of these residents' pockets, they're light. They got their patient list and they might have a phone. And that's about it. Right? It may have, there's a computer, usually a computer kind of following around one way, but that's about it. So technology has gotten amazing so that what used to be like 4 or 5 different books could all fit in the palm of your hand. So we don't have this excuse of not being able to find the information we need to find. Like that is a no-go. Like that can't happen anymore. Especially because, again, life or death things are occurring, right? People are being delayed care. People aren't given the best optimal treatment because, right, some study from some time ago said the medication does better on this race. Like we can't rely on that. That's crazy. Like we're not going to do that. And that's not going to happen, especially as we're trying to move away from this race-based assumption, especially as we try to move towards, better quality of life, equality, especially when it comes to treatment matters. Like we're trying to move towards that direction so that people aren't afraid of our system. People aren't scared to death when they have to like interact with our system. If we're trying to move in that direction, this is where it starts. Like, and I love some of these options here. Obviously, policy advocacy matters, right? There's REACH efforts. One, REACH Coalition, pressuring boards and hospitals to change clinical guidelines that are specifically focused on it, right? So not only can you focus it on the ground level, right? Just talking to your patient, talking to your provider, saying, hey, like, I just want to make sure that I'm on all the right medications. I want to make sure you give me all the options, right? Because I don't want to delay in care. I know time is life, right? I want to make sure that's happening, but stepping it up and going the political route. Again, I talk about this all the time. Health, politics, we're right here. Right. It's there is no like, oh, I can be on the health side and not think about politics. That is not true. It has never been true, but we've just told ourselves a lie. Hopefully you catch, I think I've done like 3 or 4 episodes, something similar that way. Hopefully you catch those to understand like, now we cannot afford to act like there's not policies that we can affect and change that can add to the better as well too. So extremely important. If we're trying to change for the better, it starts with conversations like this. It starts with conversations of acknowledging and not being afraid to say, yep, there's racism in medicine. Like it's amazing when I see people cower to even have the conversation because one, they already don't want to like accept any blame. I'm a physician. I'm willing to take the blame that the profession that I live, work, love, right, has dealt with a lot of racism, a lot of sexism, right? Like I'm willing to deal with all of that. Like, and if you're going to be on this side, especially working in the healthcare field, you have to be able to accept that as well too. You have to be able to talk about it because you can't provide any solutions if you act like there's not a problem. All right. So to talk again, really to kind of top it off, remember that this thing we call medical racism, it can be overt, but in medicine, I think we've done a good job of making sure it's not in your face, the racism medicine. We've done a good job making sure that it's not boom, 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 hitting you crazy, but it's in the background. It's in the medication regimen. It's in the image that they order. It's in whether they send you to a specialist or subspecialist or not, right? There's still some layers that racism is embedded within the medical field, and it's up to us, patient and provider, to untangle it and get it out of here. It's up to us to be like, all right, I see what's going on. I see what's happening. I have a problem with this, right? Because one, I'm here to take care of my patient. And if I'm here to take care of my patient, I want to make sure my patient has the best treatment options, the best treatment plan ever. And they can't have that if there are certain factors that are quote unquote above them that are playing a role in you deciding whether you give them a certain medication, whether you start them on a certain treatment regimen, whether you refer them to a dietitian, a cardiologist, a nephrologist, a transplant specialist, right? Like it's up to us in the healthcare field to recognize that, yep, there's some problems here afoot and we're going to get it out of there. So that's why it's important to understand that medical racism, it's not in the past, it's in our protocols.